Hey there, this is Brian Buchanan, intensivist at the Department of Critical Care Medicine at the University of Alberta. In this tutorial, we will break down coma and altered LOC. Let's start with what you've learned up until now. You may have learned that the approach to LOC involves first taking a history, doing a clinical exam, leading to investigations, a diagnosis, and a management plan. In the ICU, when you're managing acutely ill patients, this paradigm has to be reconstructed, primarily because our patients can be acutely ill, can drop their LOC critically, and become very unstable. Therefore, the management plan becomes one of the first things that you actually have to reach for. Getting at that can be challenging. When you're seeing a critically ill patient, the first thing you should focus on is your ABCs. That is your airway, breathing, and circulation. The airway question you should have in your mind is their airway patent? Are they gargling or protecting their airway? And are they able to expectorate upon command? Breathing, and that is, are they hypoventilating? Do they have shallow respirations? Are they apneic? Or do they have a change in their breathing pattern? Or are they hypoxic, leading to encephalopathy? In circulation, are they hemodynamically unstable? Are they critically hypotensive, which explains their drop in level of consciousness? Something you need to address right away. The next thing is a really abbreviated clinical exam. Diagnosis. Again, this comes back to your frank acute diagnoses, like acute stroke, for example, or hypoglycemia. And management. And this can be a rapid management plan to actually stabilize the patient. So really, our approach in ICU is kind of more of an acute approach, which will blend in more towards traditional paradigms. So in your approach, you'll ask yourself, are you protecting the airway? Is there good breathing and oxygenation? And how's circulation? And is there any hemodynamic instability? And finally, is there any patterns that will suggest that there's a neurological involvement, whether it's lateralizing findings or any opioid-type toxidromes? In managing critical illness, you're often forced to make at least a preliminary diagnosis. And this might be a drug-induced, such as opioids, neurological in origin, like seizure, or perhaps they're postictal, or they've had a stroke, metabolic, which may be secondary to hypoglycemic or infectious causes, or could be hemodynamic related. In many cases, however, it'll be undifferentiated, but they need their airway secured, so you can pursue further collateral history, your examination, and investigations. The universal antidotes come down to DON'T. Dextrose, oxygen, naloxone, thiamine, plus or minus flumazenil. Dextrose, obviously, for hyperglycemia. Oxygen, obviously, for the hypoxic encephalopathic. Naloxone, if you suspect an opioid overdose type syndrome where they're hypoventilating with pinpoint pupils. And thiamine for phrenic encephalopathy, which is much less commonly seen nowadays. Finally, flumazenil for the patient with the acute benzo overdose, although this drug is used much less commonly given the risk of inducing seizures. In many cases, we just let patients sleep this syndrome off. Describing and communicating altered level of consciousness is a very challenging proposition. You're often taught the Glasgow Coma Scale, which reduces level of consciousness to eye-opening, best verbal response, and best motor response. And then you're given a final composite score out of 15. Generally, breaking these components down, much more helpful communication. One might say E3, V4, and M6, for example, rather than a composite score, just so they can communicate the individual categories. But this score has really been calibrated well for head injury and trauma, but is perhaps less useful in patients with medical illnesses. You have to really think about alertness and responsiveness. And this is the real trouble. A patient can be alert, but non-responsive, and they can appear to be not alert and also responsive. Coma is really the definition, is unarousable unresponsiveness. And really, word choices matter, particularly when you're calling a consultant to communicate accurately. And another scale that you can consider is the confusional assessment method, which first of all looks at the acute onset and a fluctuating course, which again is very typical of delirium with a degree of fluctuation. Next is inattention. Again, besides psychiatric syndromes, there are a few organic illnesses that lead to a dramatic reduction in attention. Finally, disorganized thinking and an altered level of consciousness, whether they're alert, hyper-alert, or lethargic, are in fact comatose. You can also use the intensive care delirium screening checklist. You'll notice a lot of these categories are very similar to confusional assessment method. But this is the scoring system we use in the General Systems ICU, which helps us to quantify a patient's level of cognition. So it's good to become comfortable with how the score is used. There's also the Richmond Agitation and Sedation Scale, or the RASS scale, which goes from +4, which is combative, perhaps violent and perhaps dangerous to staff, all the way to 0, which is alert and calm, and the other side of the scale, which goes to -5, which is unarousable. In many cases, our target of sedation will be between 0 and -1, which is alert and calm, to very mildly drowsy, that has sustained awakening to voice. So what we hope you gain from this rotation is the ability to master describing and communicating neurological status, regardless of the context you are in. Let's review some features on history and clinical exam, but before we get there, we're going to take a little pit stop at the differential, because this will really help guide your data collection and your examination. A helpful acronym is DIMS. To break this down, first look at drugs, whether it's addition of a new drug or withdrawal of a chronic drug such as an opioid, a benzodiazepine, or alcohol. Also talk syndrome such as serotonin syndrome, opioids, obviously salicylates, finally carbon monoxide poisoning, which is oftentimes very easy to miss. Infections, broken down to obvious, which is things like UTI, pneumonias, to occult, like endocarditis, meningitis, subarachnoid hemorrhage, encephalitis, and vasculitis, which can be very difficult to pick up. Metabolic includes hepatic, like hepatic encephalopathy, endocrine, like profound hypothyroidism, or hyperthyroidism, or panhypopituitarism. There's also delirium not otherwise specified, which can include a kind of a bucket diagnosis for unexplained delirium. Also structural, such as stroke, malignancy, and epilepsy and seizures. Features that help you characterize altered LOC. We've talked about the acuity and change from baseline, and the degree of fluctuation. Also their degree of alertness. Are their eyes open? Do they respond to visual stimuli, including visual threat? Or to expand upon that, visual threat is if your hand accelerates towards their eye but stops before contact, they should typically blink in response to this. Can they communicate or understand commands, even if they're not alert? This means if they can grasp your finger, for example, upon command, can they also let go? Are they protecting their airway or gargling secretions? And finally, do they have any lateralizing deficits, like cranial nerve deficits, like facial droop, motor, or sensory? Typically, we avoid the terms stuporous or obtunded because they're vague. Again, the important parts are protecting their airway. You can describe spontaneous behavior of the patient. For example, do they respond to voice, to light, to pain? And are they arousable to noise, somatosensory stimulation, such as supraorbital pressure, Kleenex in the nose, or pressure at the angle of the jaw? And what do they do in their motor exam? Do they follow commands? Do they respond to pain? Do they localize by crossing the midline? A skill set that is important to master is the clinical exam in a comatose patient. This may begin with your vital signs and just your gross observations, but also a pupil exam, looking for papilledema, and also gaze preference. This may also require some examination with the ultrasound for optic nerve sheath diameter as a surrogate for ICP. There's also a vital signs consideration for suggestion of Cushing's reflex with bradycardia and hypertension. Extreme hypertension may suggest posterior reversible leukoencephalopathy or intracranial hemorrhage. Is there posturing in response to pain, whether it's decorticate with upper limb flexion or decerebrate with upper limb extension, or meningismus? Never assume the comatose patient does not hear what you were saying, because as I alluded to, in many cases the patient may be responsive and actually following commands or even alert, but may not appear to be so. The cranial nerve exam in a comatose patient. While a patient can't follow commands, you can still examine many cranial nerves with just observations. For example, the pupillary light reflex can test the afferent and efferent limbs of nerves 2 and 3 respectively. Moving the head side to side, like in a doll's eye fashion, can elicit 3, 4, and 6 for extraocular movements. Delicately touching the cornea with some tissue can elicit 5s and 7, the afferent efferent pathways. You can also move on to doing a gag with an endotracheal tube, which tests the afferent limb in 9 and the efferent limb, gag, in 10. The motor exam. Obviously, you want to look for posturing, any lateralizing or asymmetry in power. Is the movement purposeful? As they approach stimulus, do they push the hand away or actively withdraw from stimulus? And you can look for their overall tone in the presence of hyperreflexia or clonus. This can be very helpful, for example, in a patient who has profound hyperreflexia in the lower extremities, perhaps suggesting the presence of serotonin syndrome. Some worrisome findings: clearly abnormal respiration. Cheyne-Stokes respiration, for example, can be one concerning finding with intracranial pathology. Do they have fixed or minimally active pupils or asymmetric? It's important to consider for any baseline pupillary abnormalities. Gaze deviation, posturing, and finally the Cushing's type vital signs. Pitfalls? Well, the pitfalls of looking at level of consciousness in a critically ill patient is we often try to be parsimonious. That is, the most unifying diagnosis is most likely the correct one. But in critical illness, this is not always true. A patient can indeed have more than one diagnosis. Hickham's dictum says that a patient can have as many diagnoses as they damn well please. And it's important to realize that, because a patient may in fact have strep pneumonia and also have intracranial hemorrhage. So you need to keep your options open and always question yourself on whether or not the most unifying diagnosis is always the correct one. Other items in a sedated patient includes pain and withdrawal, which are difficult to express for a patient who can't respond. But you need to consider on your differential. Paralysis without sedation is one of those ones that would be extremely unfortunate, but certainly has been reported in multiple case reports. Undiagnosed conditions such as Guillain-Barré syndrome and delirium, encephalopathy, and also non-convulsive status epilepticus in the patient who is perhaps unresponsive post-intubation. Conditions that can be mistaken for coma include akinetic mutism, myxedema coma, Guillain-Barré syndrome, acute hypopituitarism, and porphyria. While these diagnoses are not common, they need to be on your list for potential clinical confounders. Also consider the patient can have locked-in syndrome, which may be intact cognition with complete paralysis of voluntary muscles in all parts of the body. In this case, they'll communicate through code systems such as blinking or repeated up and down eye movements. This is not a very common phenomenon, but certainly can happen. I'll tell you, in a lot of cases, clinicians at first don't recognize this, and patients can hear and perceive everything in the room unbeknownst to the care providers. There's also a minimally conscious state, which exhibits deliberate or cognitively mediated behaviors, and in fact may intimately follow commands. Finally, we talked about the unarousable unresponsiveness of coma, caused by structural, metabolic, physiological, or so on. This patient is unaware of self and environment and cannot be aroused or respond to vigorous stimulation. With a persistence of more than 30 days, persistent vegetative state, state of partial arousal, which the patient may briefly alert to sound or visual stimuli, and they'll actually withdraw to noxious stimuli, but they cannot in fact interact or respond voluntarily or any purposeful way to stimuli. This is really a chronic condition, and this is a condition where you'd really want to involve neurology. Finally, to round this out, on to investigations. This really depends on what your pretest probability is for your differential. This may include blood or urine tests, a CT head with or without contrast, a lumbar puncture, an MRI, for example, which oftentimes is more difficult to order acutely, but there are indications, and finally EEG, whether it's for a lateralizing neurological abnormality, even seizure. Of course, it's your final diagnosis that'll dictate your management plan, so this will not be covered extensively in this tutorial. Well, I hope you found that informative. I want to thank you for listening to this tutorial and hope you gained a different perspective on your approach to coma and altered LOC. Bye for now.